We're good to go? Okay, very good. Okay. Hello, everyone. I'm Wendy Chung, and I'm here with Jessica Waxler, who's a genetic counselor. For those of you who don't know me, as you'll be seeing, I'm the Chung in the Chung-Jansen, and I'm a medical geneticist based here at Boston Children's Hospital. I have been working with the family group for many years now, had a real pleasure of getting to know some of you, but actually not most of you. And as part of this journey, I think it's always important to share information about what I'm seeing and learning, and reciprocally hear from you what you're seeing and learning so that we can hopefully make lives of individuals better as we go along. So that's the purpose of this webinar today. We are recording this, so this will be available to people who may either get a diagnosis down the road or not be available at this exact time to watch this. Or if you want to share it with your doctors or educators or other providers, we're recording this. Because we're recording this and wanted to protect everyone's privacy, you're just going to see me on the screen. And then if you have questions during the session, I'm going to be giving a presentation for about half an hour or so, and then I'll leave time for questions and answers. At the bottom of your screen, I hope you can see it, but there's a little button with a question mark that says Q and A for question and answer. If you have questions at any time during this WebEx, you can type those in, and Jessica will be the one monitoring those and feeding the questions to me. And you'll be you won't be shown in terms of your name or your face or anything like that. So everything will be private. I will ask that when you ask your questions, you try and think about them in a generalizable way that are useful for everyone on the webinar. We're not going to get into very granular questions about your specific issues or a specific medication or question about things like that, but I'm happy to answer things in a general sort of way. So, without further ado, if I forgot anything else, Jessica, let me know, but otherwise I'll start sharing my screen.
You're all set to go.
Okay, and okay. And as I said, all of this information will be available afterwards, so you don't have to feel like you have to take furious notes. Um, so natural history, I will try and explain things in sort of everyday language, but if anything doesn't make sense, feel free to write it in the chat. So natural history study, just in terms of what that means what basically life is like for someone with this condition without any intervention, so without any treatment. And I say this because this serves as a reference point for us in the future, in particular, if we're ever to do clinical trials or think about interventions or treatments and want to know what impact does it have, either positive or negative. And so natural history tells us just what naturally things are like. This condition goes by a couple different names. I wasn't the one who named it, but some have called it Chung-Jansen syndrome. The gene itself is called PHIP, and some people call that PHIP. And so some people call this a variety of combination of those terms, and any of those is fine. So I'm going to go through today in terms of what we've been doing. I'll share all of the data I have through any channels that I have it. I'll also try and put this in the context of what others have been doing. There are a couple of us around the world that are working together to understand what this is like. And in a good way, I think we are being very effective in terms of sharing those experiences. I'll also say that I'm going to have a homework assignment for people to do. So within this, there are clearly to me gaps in our knowledge, and I'm going to try and surface those as opportunities based on what I've been hearing from you individually. And I am constantly trying to evolve and modify things as we go forward to meet what I think and I'm seeing are sort of the greatest needs out there. So, in doing this, just to let people know, there's already been one clinical trial that's included PHIP or Chung-Jansen syndrome, and I was part of that, and that was largely related to issues of body weight and problems with people that were having trouble with weight gain. So that was already one example of how we've used the information for treatment trials, and areas in the future I can already feel are things that are related to what I'll call the brain and behavior. And I think there are opportunities still for improvement there. And so I'm constantly trying to think 3 steps ahead as we're doing this. And given how common this condition is, and that is one of the take-home messages, is I do think this is a pretty common condition that's just under-recognized. I do think there are a lot of us that can help each other as we go forward. And the good thing is that numbers matter. And so as people think about obviously trying to help people, sometimes larger numbers are a good thing by people feeling as if there's more people to benefit from the investment of what they're doing. And so sometimes funders, like governments or federal agencies that provide grant funding, that matters in terms of being counted. So one of the points that I'll make with that is it is important to stand up and be counted. Um, I was just hearing that the numbers may be as many as 600 people worldwide with this condition. And as you'll see, we certainly don't officially know of 600 people worldwide. And that becomes an issue when funders think about where they're going to fund research, research that helps improve quality of life and everyday life. And so it is important to stand up and be officially counted so that you can advocate for resources that are going towards your condition or your family member's condition. So that'll be one of the action items that comes out of this. So what have we've been doing so far? Where does the information come from that I'll be reporting to you? And I say this for full transparency and so that you'll know how it is that we're arriving at some of these conclusions and whether or not they're accurate or not. And I don't claim that the data are perfect. They are a subset of what you're seeing because only a subset of people have really come into these studies. But we try and do this reliably. We try and listen to you very carefully, both by what you say and what you write in the surveys, by what we can see in medical records, in other words, documentation of some of this information. And importantly, things change over time. I'll be making that point. And it's important, I think, to understand that trajectory and that life course. And one of my hypotheses or one of my guesses is that there may be opportunities to be able to help support individuals over that life course. And there may be certain times in life that are more critical, times of transition, times of development. And so we're trying to listen and identify those critical times as we go forward. So what we've collected in the past and what we'll continue collecting forward are shown here. We do try and minimize the burden on you all. We know your lives are challenging, difficult, busy. They are for us as well. And so we're trying to make this sort of the most that we can get with the minimal burden on you. We do want to understand both medical issues as well as developmental, behavioral issues, and understand some of the changes or interventions you've made and whether they're effective. So whether they might be things like medications, in some cases surgery, in some cases behavioral modifications, therapists, people to help support you, a life coach, but be able to understand those things and what impact that has. There are some things that I'm especially interested in, and whether or not they might have sort of a feedback loop. Sleep is one of them. A good night's sleep certainly helps me in terms of being able to think more clearly, sort of feel like a better version of myself. And so when sleep is disturbed, that can be an issue. So that's one thing we're curious about. And ultimately, it's all about quality of life. So what things are individuals able to do, where are their limitations, and what are priorities to address? And those priorities really come from you all, come from the community, and we want to align with what your priorities are, make sure that we've got ways to measure it, because that's what happens when we try an intervention is we want to be able to measure that change and make sure we've got an accurate way of doing that. We try and do things that give us robust data, so data that other people trust, whether it's your doctors, your providers, ultimately people who pay for care, so insurers, people who make policies. So we try and design all of this to meet their standards, as well as I said, be minimally burdensome, whether it be for travel and to be able to have people who can participate online from anywhere. That way we can be maximally inclusive. So we do have many things that are online standardized scales like the Vineland Adaptive Behavioral Scale. And if we need to, over time, we will modify or make some measures that may be more specific. So let me do a brief rundown of our most recent publication that's not quite a year old, but this is from a data set based on 47 individuals who have participated in studies for which I have access. And I'm not showing any individual person as part of the research, even though you might enter the data personally, we don't identify who anyone is who participates in these studies. So the first thing, who's represented within these studies, it is interesting in this that we do have a little bit of difference between males and females, a few more males than females in the research studies, and that the age distribution is largely representing younger people, that is, individuals less than the age of 20. You will notice, though, that there are adults, and in fact, I know there are many adults out there. I think they simply don't always get genetic testing. In fact, usually don't get genetic testing, and that's why we don't see more of them. But it's not because I don't think they exist out there. This is for some of you, probably not most of you, but if there are scientists listening to this is showing the distribution of different types of genetic variants that we see within the gene. There's a certain type of variant on the top, which we think basically destroys one of the two copies of the PHIP gene. The variants on the bottom or below the stick figure here are more subtle variants, and we call those missense variants. The point that I want to make, though, is that basically everyone is unique. That is, that when we see this, these represent each a different person, and each person really has a different genetic variant. And it is even that much more important that everyone stands up and is counted, because within this, there may be differences by the genetic variant within the gene, and for us to understand. And at some point, if treatments, in fact, are specific to the individual variant, if you're not represented within those studies, I don't have ways of being able to direct future research, future therapies to things that might be relevant to you. These are not randomly distributed, in particular along the bottom. We tend to see clusters within this orange bar here, and I won't go deep into the science, but just to say that's based on the biology of how this gene works. Going through, starting with some of the things that affect the brain and behavior, many individuals were delayed a bit in terms of some of those early milestones when people walked or talked or learned how to ride a bike or spoke in full sentences. But people get there. That's the point that I want to make is they do get there. It may take a little bit more time, but they achieve all of those regular, we call them again milestones, but as kids are growing up. But there can be things that come up, and they come up at different stages of life. And that's important. Some of the things that we are seeing in adults, we don't see in 2-year-olds, and that stands to reason that's developmentally appropriate. But we do see things like problems with attention, impulsivity. Some individuals, about a third, will be diagnosed with autism. Individuals may have anxiety that seems to also evolve over time, more so when individuals are in adolescence or adulthood. And here on the bottom is what I was suggesting before, sleep problems in a little over a third of individuals. And so that's one of the questions. If we had ways of, or at least my question, if we had a way of improving sleep, would we have other ways of improving other related conditions? This is now giving you more of a life course view of things. And so we've broken this down by age. So for each of these different symptoms, on the left is attention deficit hyperactivity disorder, or ADHD, anxiety, depression, sleep difficulties. And the numbers are modest. I do want to underscore that. There are a little over 10 in each of those age categories. And if you look at them, they're broken down with the youngest of those bars being 6 to 12 in white, the middle bars, adolescents, 12 to 18, and then the bars on the right for each of the categories, the adults. And you can see in particular when it comes to depression, not surprisingly, we don't see much depression in the children who are age 6 to 12, but all of a sudden this bumps up. You hit adolescence, and now 50% approximately of individuals have trouble with depression, and that continues on into adulthood. And in not dissimilarly, anxiety takes a big bump up in adolescence. And again, think of these as transitional times, times that both our folks are transitioning, other kids around them in their community are going through transitions. But with a lot of that change, I think comes some of that anxiousness as well. And then I would say for sleep, really across the life course, we're seeing problems with sleep. So that may be something more universal. The Vineland Adaptive Behavioral Scale I mentioned before, you can think of it, and many of you or some of you have done this. It's an online questionnaire, and there are multiple we call domains or areas that we break this down into, but it's meant to be a reflection of what individuals are able to do in day-to-day life. Um, each one of these is a number one broken down by age. So in blue are the younger individuals, birth to 12, and then in green are the individuals age 12 and above. These are, we call them violin plots because they look kind of like a violin, but you can see for the different areas of adaptive behavior, communication, daily living skills, or socialization or interacting with others. Each of this is a distribution of the scores that we see in the general population, so for quote unquote neurotypical individuals, the mean in the general population is 100, and the what is called the standard deviation or the differences across a population are 15. So we consider that the distribution in a quote normal population or community would range from 70 to 130. And so 70 would be right about here, if you can see my cursor. And the point to that is that almost everyone in the community is in the normal range for all of these things on the Vineland. There are a few people, I'm not saying absolutely everyone, there are a few people who tend to be lower than that, but most people are in the normal range in terms of their adaptive behavior. However, most people are below average, so below average within the general population. So there's some challenges. I will say that one of the things that I find especially challenging is that many individuals report to me that most other people see them as normal. They see them, they look the same, they don't look anything different. They are able to do so many things, and they are normal. They're in the normal range, but they do have challenges. And so with that, they're hidden disabilities or they're hidden differences. And I think people find that especially challenging. And so I'll underscore that, and we're going to come back to it in terms of the things we're planning later. But I do find that to be one of the things that's unique amongst this group compared to some of the other groups. Um, Things happen, change over time, and many of you have heard me say before that weight is one of those. And it also becomes a little bit more complicated because individuals may be taking medications, and some of the medications, it's important to let your doctors know about this because when they go to prescribe the medications, some of the medications can be associated with weight gain as well. So there may be issues with that. Okay, so looking at this, I've just broken this down by percentages. Certainly, a lot of people, and this is from that same study that I was alluding to, a lot of people, about 42%, are in the normal range for weight, and we take this by age. So there are differences in what we call normal for different age groups. Little babies, for instance, are often chubby wubbies, and then sometimes kids get, they're like string beans as they go through their growth spurt. So there's sort of different normal ranges at different ages. There are a few people that are underweight, but you can see that there are individuals who have problems with being a bit on the overweight side, but then also people who have problems in terms of really weight that's in a range that's not healthy. So what you can see is that the plot over on the left is showing individuals from birth up until, young adulthood here. And you can see that in our group, this is called a body mass index. And so this is a measure of whether sort of what the weight is in proportion for the height. So whether or not things are right sized. And you can see that our community gets heavier, gets a higher BMI over time. And this is technically for anyone who's really into this, something called a Z-score, which normalizes or takes into account that there are these, like I said, chubby babies or skinny string beans during certain growth periods. So all of this is taken into account, but you can see that over time, even though people start out, zero would be just like the average population and would be quote unquote normal, that it tends to drift up over time. And so this is something that in an important way you can anticipate and actually try and preempt. And some of those things are healthy lifestyle habits, being physically active, walking rather than riding when it's possible, good healthy eating habits, drinking water rather than sugared drinks. So things like that that just get integrated into your life. And so they're not a difference, they're not a change. And this is true especially for those of you who may have little ones who aren't experiencing these challenges yet. There are some medical issues. Thankfully, most of these are not, this is not too medical a problem in terms of life-threatening or life-altering medical things. But there are certain things that are addressable in an important way and can really help. So overall, with eye care or vision issues, these are quite common. And almost everyone has something, or two-thirds of people have something. Sometimes it's something where you need glasses. Sometimes people need patching. Sometimes people might have problems with astigmatism or a lazy eye, and they might need even surgery. Not usually, but that is possible. But the point is to get this addressed, that the sooner it's addressed, the better it's addressed, the clearer the vision is. And with that, just being able to accurately see the world and interact with the world. In the same way, thankfully, it's not as many people, but there are individuals with hearing issues, something that may need to be addressed if there are lots of fluid in the ear, where ear tubes can help relieve that so that people can hear clearly, hear conversations, learn. Because they're hearing clearly, learn language, learn at school, and just make sure they're part of the world around them, able to interact with conversations and hear those conversations clearly. So usually easy things to address, but make sure those are okay. In terms of other things, as I said, thankfully, these are not very frequent, but gastrointestinal issues or tummy issues are something that are frequent. Oftentimes, it's issues, a combination of what I call constipation and reflux or heartburn. Those are things that we see frequently with neurological conditions. So this condition is not unique. Many doctors are very familiar with how to treat that. Constipation with certain medications, activity, physical activity is good here, dietary changes in some cases. Lots of relatively straightforward ways to do that. Addition of fiber to the diet, but it's kind of getting on a regular routine often is what's most helpful. In the same way with reflux, some people may not need medication. Some people may need Tums for heartburn. Some people may need other either over-the-counter or prescription medication, but something that's relatively straightforward to manage. Up on the top here are some of the neurological issues. Lots of times what people will notice is that the tone is low. Just the overall, there may be problems with people being clumsy, not quite as coordinated, not the most graceful person, needing to really practice, practice, practice to be able to get certain things down. And it leads to some people, for instance, not feeling confident in playing sports, not being part of then socializing in those communities, maybe not for some of the individuals not participating in some dance classes or dance routines or cheerleading or things like that. So this can have manifestations because of this difficulty. But with practice, sometimes that muscle memory kicks in. And so, again, for individuals who really want to do it, practice, practice, practice. And of course, many times, I, myself, I'll admit this, I'm not the best dancer, the best athlete, but you can still do things just because they're fun. That you don't have to do them competitively. In a good way, not so frequent to see things like seizures. Very small number of people who have seizures or anything like a neuropathy. So these tend not to be big medical problems. And on the lower right, very low frequency, but sometimes people had a heart rhythm or palpitations, very low frequency, but congenital heart disease. We do see, as I said, things that are more related to, I'll call them endocrine, but other issues. And some of this we may see more over time as some of the individuals have problems with their weight. Diabetes can come with that. So that is something I'm watching closely, but is not an issue yet. Some of the females have had polycystic ovarian syndrome that can come with obesity as well. So that's something we're also watching. And then some of these things that are a little bit more frequent, a little higher frequency of urinary tract infections. And then for males, undescended testes, or what we call cryptorchidism. So, and that's something that can surgically be taken care of if that doesn't resolve on its own, if the testicles don't come down on their own. Um, We've even seen, and actually some of the kidney doctors have been recognizing this as well, that there's a higher frequency of structural kidney differences. This is, since the last time I think I talked to you, become more obvious. And so something that, especially for individuals with urinary tract infections, good to get an ultrasound to look at the kidneys, because there can be some times when there might be urinary tract infections that actually might do some damage to the kidneys. And if the kidneys aren't quite perfect as they start, even more important to clear those infections and make sure all that's okay. Finally, in terms of the bones or orthopedic issues, we do see a slight increase in that during adolescence, especially when that growth spurt is going on. There may be curvature of the spine or scoliosis. Many of you may have noticed on your own that there's webbing of the toes or syndactyly. We can see that, or slight curvature of the pinky. These don't functionally have any significance, so nothing to worry about, but just to explain the why question, why you might be seeing that. So now I'm comparing all the way on the right what we saw in our study versus what's been seen in a couple of the other studies. And the bottom line on this is that they're very similar. So we're seeing similar things across the studies. I think as we've been probing a little more carefully, our study may have been seeing a little bit more of the sleep issues as a distinguishing feature. But I think in general, we're tending to see similar things across the studies. Sometimes a little bit more, a little bit less, but nothing wildly different. So that consistency makes me pretty confident that what I just said is true. Okay, let me switch gears now. So that's mostly catching you up in terms of what we've been seeing and publishing on. And now I'm going to make sure we're looking forward. And looking forward, I am trying to advocate for you. And in doing so, the more evidence that we have that this condition is common, and to understand where are the areas that you need help in, become really critical. So this is now going over and reviewing for you how you can partner with us in going forward. So there are two related studies. I'm in charge of both of them, and some of you have participated in one and some of you in the other. But just to let you know, because these studies are both studies that I run, I'm what they call the principal investigator. We very much put the information together across these two. One of them is called Simon Searchlight. We've been doing that for a long time, about 15 years. The other one is called Ascend, or Advancing the Science, Care, and Exploration of Neurodevelopmental Disorders. These are data from the Simon Searchlight study, and just to let you know that some people get stuck along this process, and I think it's probably because we don't do a perfect job of communicating what the steps are in the process. But for both of these studies, they depend on making sure that you're in the right club. And by doing that, we review your genetic test report, and in reviewing that, make sure that this is the right diagnosis for you. And I have had circumstances where people have come to me, and in fact, this this was not their diagnosis, and I helped to get them to what was their diagnosis, but we want to make sure you get the right diagnosis. Within this, I'll say this again a little bit later, but some of you have so-called variants of uncertain significance. That is, that it's not 100% certain yet that this is your diagnosis. And I have a new opportunity specifically for those of you that might be in that sort of, I call it purgatory, that is not quite knowing for sure if this is your diagnosis. But again, the reason why we ask you to provide to us a copy of your genetic test report is that we want to understand what testing you had, what the laboratory thought of your result, whether or not we agree with that, and anything that might be a slight nuance that might be hard for you to understand, but where we understand very quickly. Beyond that, that's kind of the gate to go forward. So we had 19 people register in Simon Searchlight, 15 that provided its genetic test report, and then 7 people, and I'll say actually only 7 people that went on then to provide information about their medical history and begin filling out surveys. So for those of you who may have done this before, you can easily go to the Simon Searchlight website and from there log into your account and keep moving along this process. We've also had individuals who have been doing the Ascend study. And so within that, 30 individuals who had contacted us at some point. Similarly, there's a sort of attrition or people that get stuck along the way. 21 individuals who signed the consent form to join the study. And if people don't want to do the study, I want to be clear, you don't have to. You can certainly find out. And if it's not for you, perfectly fine. No one is forced to do anything. But I just want to make sure people didn't get confused about thinking they had done what they needed to, but realizing there was more to be done. So 21 people went on, and then 14 went on to be able to either provide medical records or start filling out the online surveys. And both of these, again, available to people from around the world. Um, in doing this, we're trying, especially with the Ascend study that I'm doing through Boston Children's Hospital, to address the issue I've been hearing about challenges that people have, especially when it comes to behavioral health issues. And so I've brought in a psychiatrist here at Children's who's going to be going and doing a much deeper dive to understand the issues as we try and also listen for what have been the successes and try and collate across individuals what those successes, what's been helpful, what's worked, and trying to think through that so that if there are things to be shared about what will be helpful, making sure that we can do that. And so as we're doing this, as I said, we'll be facilitating this and all of this available online remotely. So you don't have to be here in Boston, even though we're coordinating it through Boston. So for these studies, and again, Jessica and my team here will help everyone navigate through this if they're interested. And I'll have the email at the end you can email us at. This is inclusive of individuals who have a genetic diagnosis we think is definitive. Technically, we use the terms pathogenic or likely pathogenic. And for those of you who have those variants of uncertain significance, please register with us because I do have a way of being able to now test those and being able, and it's a very expensive proposition for us to do this. And so it does, and I don't know of any other group that's willing to do this, but we're going to try and resolve these and get people definitive answers. So we want to be able to hear from you and be able to help those of you who might be stuck at that point. As we do this, we'll give this information back to you. For those of you who are in that uncertain area, I will warn you it's going to take some time, probably even more than a year, because we're going to wait till we get enough of these and study them all at once. And so depending on when you come in, it might take a while to do the experiments and to get enough people to do the experiments. This is who I mentioned. Some of you know already, Jessica Waxler, a genetic counselor. And then we have others that are behind the scenes, Candace and Emily, who are powering this. And if there's something you wanted to take a screenshot of or to be able to write down an email address to contact us is this email address, ascendstudy@childrens.harvard.edu. And you can contact us there for any questions in general, or if you'd like to do any of the studies that I've been talking about today. If you're not already in the study, then again, we're going to ask you for a copy of your genetic test report to make sure that you're in the right study. We're also going to perhaps ask you for certain medical records to understand so that you don't have to understand all of the technical mumbo jumbo that we use. We can directly find that from the medical records. And in some cases, if you have them, we are interested in understanding the brain electrical activity as well as how the brain works. If you don't have it, it's fine. It's not a big deal. But we are trying to just get as much and learn as much as we can without incurring additional cost to you or need for travel. So we're trying to put all that together remotely. Again, just to set some expectations in terms of how long things take. I don't want you to be surprised by any of this. And you can do this in pieces. You don't have to do everything at once, although I think sometimes people do a piece and think they're done. So I wanted to outline for you all the pieces so you'll know that maybe you're not done yet. The first is to email the Ascend study. The second is to do this again, sort of first initial registration and uploading your genetic test report, which hopefully takes 15 minutes or less. The second one is to sign a consent form, permission that you're giving to enter the research study. Depending on whether you're a fast or slow reader, that might take about 20 minutes or so. And then you actually start the process of being able to provide this information about the medical information, as well as I mentioned it before, but this Vineland score, which helps us to know how people are doing in a general broad sense from a sort of functioning in day-to-day life. And each of those, again, depending on how complicated your medical history is, takes less than an hour. Within those, we're also, as I said, doing what I think is going to be actually incredibly helpful to the community. And that's that behavioral concerns keep coming up in terms of how people are changing over the life course, what they're dealing with. What I think some people are worried, is it just them, or they are the only ones experience this, or how might others have navigated this space, and are there things that we can learn from each other? And so in doing this, we're taking it quite seriously and dedicating significant resources to try and work together. As I said, we've got a dedicated psychiatrist to be able to help think through this. And ideally, we're going to do this as a perhaps a family affair in some cases. And so I say this because you can think about whether you want to do it alone or you want to do it with a family member. And that may depend on your family structure and how old you are or how old your family member is. So this is meant to be flexible depending on what the situation is. So, as I said, our study team will help coordinate the scheduling of all of these things. But as we get to the specific things that are around mental and behavioral health, there's some specific surveys. And I realize these take a bit of time, but it's because we want to get it right and we want to understand what the issues are. And we want to be able to present back this information to you all as families in the same way I've been presenting the first part of today. So there are some surveys online, depending again how quickly or slowly you go through these things, take an hour or two. And then there's a portion of this which is online or telephone, depending on what your Wi-Fi connections are and what you're comfortable with. But you're one-on-one then talking with our doctor. And with this, this can be the participant themselves with the PHIP or the Chung-Jansen syndrome. And then whoever is their primary person, the closest person, either a caregiver or a parent who knows them very well, or a caregiver who knows them well, who can report on things as well. So that may give us two different people in some situations. Now, if your child is 2 years old, your child isn't certainly going to get on and talk on this interview, so that'll be just the parent that's reporting. And similarly, if you're 40 years old and you feel like you don't need your parent reporting, that's perfectly fine. You can do this by yourself. So in doing this, this is obviously confidential. We're keeping this information to ourselves, and anything we share would be de-identified. So no one, if the data were published or presented to the group, just like I did today, I don't think you can tell anyone by person or where they live, who they are in terms of any of this. But I do hope that this will be broadly helpful to the community. The part that's online and we anticipate is probably, again, going to be somewhat involved. That would take maybe an hour for the caregiver part of things. Ideally, the surveys are done first, and then the caregiver doing their online interview first, and then the person with PHIP or Chung-Jansen syndrome last. So it would kind of go through those steps as we're going through. And in doing this, we understand that that's a significant commitment of time. And as I keep saying, reciprocally, we will be giving this back to the community as a whole. So why do this? Why bother? Number one is that I think there are not too many people that are interested in your condition and interested in working with you going forward. We are, I think, that group of people, though. We've been thinking about this for a very, very long time. I've been seeing this both because the number of people have increased, and I feel like I've got a good sense and a good intuition and have been able to meet several of you. And so with this, I do think that we are getting much better at understanding the issues and in advocating for you. And so as we can advocate for getting resources for the community, helping guide you individually and collectively, help your own doctors advocate for you for what are the treatments that you need, what are the resources that you need. I can tell from the individuals of you that have been my patients that, as I said, it's been a little tough for some of you, I think, because um, there's a hidden difference, and I don't think people recognize that, and I don't think oftentimes people are giving you the benefit of the doubt. And so we need to really be able to have this well documented, accepted in the medical literature so that you can get the resources that you need. And your family knows how to work with you as well. Your teachers, your employers, anyone who's working with you, supporting you, they can know how to do that best. And so we need this to be evidence-based, rigorous, make sure we're doing the right thing. So this is your opportunity to stand up for yourself as you go forward. So I'm going to keep this up for just another minute, but this is again the same address I showed you before, but the Ascend study at children's.harvard.edu. And you can either send questions or you can sign up. And as you're doing this, either if you put something like PHIP in the subject header, PHIP research study, behavioral study, anything like that, but especially if you get PHIP into the subject line, then we'll make sure that we route the questions to the right person. So with that, I'm going to stop. I'll keep this up for just one more second. And Jessica, I'm going to call on you to help me with any questions that are out there.
Yeah, so there's some questions coming through about logistics. So I think you may have answered some of them as you were talking. It looks like there's some questions about how to sign up for studies. How are we going to hear about clinical trials? How do we get more information about the uncertain diagnosis category? Consent forms. So I think the entree point, just the short answer from my perspective, is email that address, that Ascend study address. But Dr. Chung, feel free to weigh in a little bit more if you'd like.
Nope, that's absolutely right. So if you have any of the questions that I just saw in the question and answer box, you can put all of those into that same email address and just say, I think I have a variant of uncertain significance. How can we work together to figure that out? We'll answer that question. If you say, I'm interested in signing up for a study, am I eligible? You can ask that. You can say, I think I signed up for a study, but I think I'm stuck. Can you tell me where I'm stuck and what to do next? You can write that. If you say, I'd like to look at the consent, I'm not sure yet. Can I read over it and see if I have any questions? We're happy to send you the copy of the consent or the place where you can see the consent. To really almost any of the questions that I'm seeing coming up. You can certainly, ask anything specific now, but we can also follow up offline.
So another question came through about the costs associated with the studies.
Oh, great question. I'm sorry I didn't answer that. Free, totally free. So anything that I've talked about, whether it's understanding the variant of uncertain significance and what it means, whether it's about talking with our behavioral health specialist, being able to do the research studies, all of it 100% free. So there's no cost at all to any of the participants that do this.
Can you address if international folks can participate? I think that's another question that people have, is that people outside of the US, is that possible? And are there
Yeah.
any other hoops that need to be jumped through?
Yeah, great question. So there's no limitation to international. People from around the world can participate. Um, I have to admit, in terms of languages, depending on which language you speak, we may direct traffic one way or another. I don't have this translated into every single language around the world, but if you speak English, absolutely no problem. And we're trying to increase capacity for a number of different languages, and or as we see what languages are coming up, options for different translation services. So I won't claim we're perfect for every single language, but we certainly, I think, can accommodate the majority and are getting better at accommodating even more. And we will, for people who may be international and time zone shifted, we'll see how many folks there might be, for instance, in Australia. That tends to be our most complicated based on the number of hours with time shifting. But usually for other places in the world, we can find ways to accommodate so that it's not in the middle of the night for you and not in the middle of the night for us. Okay, very good. I know it's a weekend and people probably have lots of family plans and things, so I'll give it another 60 seconds if anyone wants to put questions in. Otherwise, for anyone who joined late, we have recorded this session. You are not visible to the rest of the audience here, so everything is completely private in terms of who you are with the questions. We don't know who's asking the questions, so everything's 100% private within this. And we will post the video so that others can watch it who weren't able to join today, others who might get a diagnosis later, but your privacy is protected within all of this. No one will know who you are.
Oh, a couple more questions came in. Are you aware of any trials that are coming up? And then we can go to the next couple of questions after that one.
Okay. So in terms of clinical trials, I briefly alluded to it, but just to say there was a trial using the medication setmelanotide that was run. I was one of the physicians that was included within the study, but it was not run by me per se. It was run by a company called Rhythm. I did notice in my patients that they did respond to the medication in terms of weight loss, and so that was effective for them. I'll also say that there are now, since that trial was run, now there are effective medications for weight loss that many of you have probably seen. These are the GLP agonists, and I've seen them be effective also for individuals with Chung-Jansen syndrome. So I think that's good news for us. I think that can be quite helpful. Clinical trials that might be for other dimensions, in terms of learning, behavior, development, things like that. There is nothing on the horizon in the near term that I know of, either for me or for other people going forward, either other researchers or other investigators. I'm not saying there couldn't be, but I am saying that I don't know of anyone yet. And I do think what that really means is we've got to raise awareness. We've got to get our numbers up in terms of standing up and being counted. And we need to hear what you want clinical trials for. What do you want help with? So the first step in this for me is this, I think of it as a needs assessment from the group. And with this, I'm happy to talk with people offline or take individual suggestions by email, but this is the road to future trials. And I am running clinical trials for other conditions, so it's not that we don't want to. It's not that we don't know how to or know the steps in it. Your community is just sort of earlier in that process. But I do hear the numbers. There are conditions that are about the same frequency as your condition that are moving forward. So I think it is not potentially for lack of numbers. I think we just need to get a little bit more organized and pull ourselves together a bit more.
There's another question specific about the syndrome itself, and any insight to complaints of sore legs and what a muscle biopsy might show.
Yeah. So very, very early, I'll say that I had heard from people, I mentioned hypotonia, but I'd heard from people fatigue, and fatigue in terms of just not being able to walk as far, not being able to play as hard or as long. In some cases, at the end of the day, feeling like they needed a leg massage, sort of the fatigue and the pain that went with that. I have, I think that is a real thing as part of this condition, more so than other neurodevelopmental conditions. And so I do think that's real. I don't think it's anyone just faking it. I don't think it's in anyone's imagination in terms of doing that. I will say that I don't think we have enough information in terms of knowing what's going on within the muscle. I hate a muscle biopsy, for those of you who don't know, involves actually a surgical incision and taking out a piece of the muscle and looking at it under the microscope. I don't know of many people who have gone to get a muscle biopsy. A few that I have seen, but not a large number. And so I'm kind of on the fence in terms of what we would do with that information and what we would do differently. Certainly, this is part of what I consider the needs assessment. With such a large community, I'd love to know how many people have had a muscle biopsy, what that muscle biopsy actually showed. Could we put that specific as a point of a sort of question in the community? Could we put that out to the community, put it together? Maybe you've already addressed it on the Facebook page, and so maybe you already know. Just so that you know, I don't go and intrude on your Facebook page. I give that to you guys as your private space. And so if there are things like that that you know from each other, just to let you know I'm ignorant, and that's feel free, someone can let me know what you're seeing, and without being very specific to whose information it is. So with that, I'll say I do see the comments in terms of there may be one biopsy that showed some increased glycogen or increased lipids, and sometimes you can see that with just that being a sign of what's going on with the person's body weight and level of activity. It may not indicate a myopathy or a fundamental problem with the muscle itself. It may be just indicating other things about that person's activity level and what's going on.
In terms of getting some of the information out on on other websites, advertising for these studies, I'm happy to connect with anybody. You can definitely reach out to the Ascend email, and called to my attention. I'm happy to kind of share approved information, how to get this out, make sure that people can join and know how to join.
And we're happy to post this video on the website too. Share that file with you so you can do that.
And then it looks like there's a question about how common is it to have a second child with Chung-Jansen syndrome after a de novo mutation?
Yep. I didn't go over this because I've done it in prior webinars, but I won't say most, many people have a so-called de novo mutation or new mutation in the child with Chung-Jansen syndrome. That is, that when the parents do their testing, we don't see it in either of them. Usually that testing on the parents is done from a cheek swab or a blood sample, and we're not directly testing, for instance, the sperm or the eggs. It doesn't happen very often, but to answer the question, it's about 1% of the time that it will happen again in a second child, even though it looks to be a de novo mutation. So it doesn't happen very often, but I understand there's a concern. For anyone who's really interested, email us and we're glad to walk you through this offline. We've actually developed a way of checking the sperm, so a sperm analysis directly to see whether or not it looks like it might happen again, at least from the man's side, the father side of the family. We don't have a way of sampling the eggs from the woman's side of the family. We can't do that, so that's a limitation. For people who are especially concerned, there is a way to test for this once you are pregnant. And again, it doesn't happen very often, but some people would like to check at that point. And there are ways, and you can talk to your obstetrician about ways of testing once you are pregnant. That can be done very safely, very effectively, and relatively early in the pregnancy as well, usually by about 10, 11 weeks of the pregnancy.
Could you speak a little bit more to the incidence of the syndrome and sort of
Yep.
estimates from last year's session and kind of whether that number has been revised or not?
Yep. So I was estimating that this was one of the more common neurogenetic conditions. I'm now doing a very comprehensive study that is somewhat related to this. It's called Guardian, and it stands for Genomic Uniform Screening Against Rare Diseases in All Newborns. This is a study that currently I'm running in New York City, and it's looking at newborns, and it's looking for conditions where we see something that we might be able to help those children grow up healthier, and in some cases, really much, much healthier by early identification and early treatment. That is a true population-based study. That is, every baby born at the hospitals where we are gets the ability to enter this. And that really is the way to be able to get a true estimate of how common a condition is in the population. Um, I'll just say that we have, in fact, identified a newborn from that. So I know that number one, and that's having screened about 14,000 babies so far. And so 1 out of 14,000 is not a very accurate way to estimate that. If and when we get to the goal that I have of 100,000, I think I'll have a much better sense of what the true population frequency is. And I think that's actually going to be our best estimate. For conditions, and I anticipate that this will be one of the conditions where we have a higher estimate of the frequency from newborn screening than we do from based on the genetic testing for who has symptoms. What that says to me is there are many people hiding in plain sight, is the way I see it. So, in other words, many people who aren't getting genetic testing, but they're having symptoms. That could be because they're functioning at a level where they're not having any problems. And because they're not having any problems, why would they bother getting a genetic test? Those individuals actually, to me, are some of the most potentially valuable, insightful individuals, because if we can figure out what happened to them and what they did over their life course that buffered them or helped them to achieve more, they may provide some answers for us in terms of what individuals can do that may be helpful. And so at the end of the day, to me, it's important not just to look at newborns, but also to look at older people as well. And for some of you that may have inherited variants within your family, so not these de novo, but the ones that are transmitted from a parent to a child, those may actually be running all throughout those families with many, many family members who have this, many of whom are perfectly fine. And understanding again what buffers those individuals could actually be incredibly insightful. And so for those of you who might be interested in partnering with us to understand that, please also email us at that Ascend email address. You're a particular group of individuals that we'd like to help to be able to help your family if you're interested in doing that, and we can help you get access to the right genetic testing if you haven't had it to look specifically at this PHIP variant in your family.
So there's another question. Are you aware of any links with other genetic conditions and mutations? So kind of other unrelated things running in families.
Yep. So as far as we know, no. The simple answer is no. Any one family could have something else, though. So any one family could also have a history of heart disease or breast cancer or other things. So those, depending on the size of your family, there might be several other things in your family, but absolutely there could be other things completely separate from this that are going on. Because none of us is perfect. We've all got something, and we've all got something in our family. So.
I can take the one about how quickly you can expect a response from the Ascend email. There is a team of us that is checking that email. We strive to get answers back as quickly as possible, but if something comes up, we need to look into something for a response. I'd say 2 business days is a good estimate, but we try to do sooner than that. Can you weigh in? Next question, can you weigh in about any medications that are more successful for behavioral issues, anger, violence, etc.?
So this is actually the main focus now of this next segment that we're doing, is to understand what are the behavioral issues, understand what are the medications, and really it's through some of those interviews that you get a lot more. It's a conversation in terms of going back and forth. And the questions that we've been asking, I think, are hard to get a lot of that detailed information. So the short answer to your question is, unfortunately, no. We haven't seen a single medication that works for everyone. I don't know that we will, even with, what we're going to do in the study. I don't know that there's going to be a single magic bullet. I'll also say, based on my own observation, many people have required more than one medication. That's been quite typical, and different people at different times in the life course. So I don't be surprised if your doctors end up suggesting more than one medication. And right now, it's mostly trial and error, and I know that's frustrating. So we're going to see if what we can do to be able to make that less trial and error, and at least higher chance of success at the beginning as you're choosing medications.
So the next question is kind of how to be counted without participating in a study.
Yeah, that one, I have to be honest, I actually don't know. So what I mean by being counted and what we go through in doing that is that we do look at the genetic test report to verify the diagnosis. So it's just being absolutely sure. And it's not that I don't believe you. It's just that some of this is gobbledygook and I think can easily be misinterpreted on those very complicated genetic test reports. Um, so with this, of course, we wouldn't take in information for people who didn't want us to, but the way for us to take in information is for you to give us permission, and that's through a consent. So otherwise, as a family group, you can certainly stand up and be counted there in terms of your numbers and for whatever advocating you want to do. Certainly tout your numbers in that way to whatever agencies or, in whatever way you want to advocate for yourselves. But for me as a researcher, I do need to be able to have your permission, and that comes through that consent.
I recognize we're coming up against the 1 o'clock hour. There are some more questions in there. I don't know what you want to do about proceeding with those.
Yeah. Let me just check. Are you able to download the questions so that we can answer them offline?
Yes,
Okay.
I'm happy to take that.
Okay. So I'm just scrolling through this. So we'll answer things asynchronously, in other words, afterwards, and we'll get these out to you somehow. Let me just answer and I know we're over time. Um, some questions about young children in particular. They're important interventions or things that people can do soon, and things that might be related to children with autism or adaptive functioning issues. So, a couple things within that. I think even just being able to see from the older individuals what's going on, our hope is that you can help support young people, because I do think a lot of this is adapting your behavior in response to something. And so if you can get on the right track early, I do think the outcomes will be better over time. So what are some of those things? I think change is hard. You're seeing the anxiety, and change is hard. Surprise is hard. Not anticipating things is hard. And I think this is true throughout the life course. So as much as you can do in terms of being able to help the person in your family anticipate, that could be through a visual schedule. It could be when something is new is going to happen, showing them a video of this because you can see it online. If they're going through a new routine, talk them out through it a week in advance, the night before, the day of. But the more you can anticipate change and help them envision or be able to prepare for that and know what to do, I think the easier things are. In terms of things, again, what I said I think is true, which is that from the outside, many people may not realize that there might be that anxiety inside. There might be misinterpretation from individuals, what they're hearing and what they're understanding. There might be a gap in what the person says and what they're understanding that to mean. And so a little bit more facilitation, interpretation, support within doing this so that you can help to read some body language, help, and this sometimes comes in related to the autism diagnosis. So whether it's support or scaffolding, but things that will facilitate and where there are misunderstandings or people that may not appreciate what your child is feeling or sensing or misunderstanding, being able to facilitate that. I would say if it's possible, the more stability there is, and I realize the world's not a stable place and sometimes people move, but when the child in growing up has a stable community around them with people who know them and know sort of their differences and are accepting of them and support them, the longer they have that group around them, I do think that ends up being helpful and supportive in the longer term. And so if you can find for a young child, if you can, find a place to live where you've got good schools, good support system, and your child is growing up in that community and has, whether it's a school based, whether it's who's in the neighborhood, who's at the playground, who's at your church, but, different groups that are really kind people that are supporting and understanding, all of those things help. And it's true for me too. All of those kind people around you help you to be your best and understand where you might need a little extra support.
Can I just interject a little bit to say that coping strategies, coming up with coping strategies for people when they get dysregulated is very important. Everyone has a different coping mechanism, healthy coping strategies. So, you kind of have to talk to your child or decide what is going to be best for you. If it's, taking deep breaths or whatever it is, that's going to be very important because when things go wrong and things do go wrong, that if instead of getting completely dysregulated and having a really hard time to be able to suggest to the person what coping strategies have worked in the past. And just something that we have noticed because our child is now 21 years old, while we were talking to our psychiatrist about medication, that I think is really important to understand. First of all, medication is not going to be the be all end all. Like your child is not going to just magically behave because they're taking medication. It may be helpful, absolutely, but it's not going to be kind of a magic solution for anything. And also, it was pointed out to us that the children or the people taking the medication may not have the pathways that the medication works for. So if there's no pathway for the medication to work, then the medication won't work. Does that make sense? So that was something that was very like mind-blowing for me. Was the psychiatrist said she may not have the right pathways or the pathways may be interrupted because of her syndrome. So the medication is not going to be successful in working because it's not there.
Thank you so much, Elise, for chiming in. From Dr. Elise, who I've learned a lot from and her family over the years. Okay, very good. We will wrap up by, as I said, some of the other questions offline. Just to say very briefly, there are some individuals who have mosaic mutations. We can talk to, it doesn't happen very often, so we'll take that offline. There are some times, as I said, where this is inherited from a normal parent, and those individuals, I don't know the specifics of whether or not that PHIP genetic variant is actually the diagnosis. It may be, and that you're one of those families that I said where we see it being passed through a family with normal individuals, and you've got some buffering and some superpowers that are amazing. Or it may be that this is not the answer, but we can help try and resolve those on a one-on-one basis offline if you're interested. And some of the issues that do come out in terms of that regulation can come up with some oppositional defiant disorder, and especially I think in males, gets labeled that and can be challenging in the school situation, and until individuals learn how to self-regulate or have help with that. And so I know that can be challenging both to find the right school setting as well as to be able to cope with those behaviors. So I want to thank everyone, Jessica especially, who organized and set everything up, Elise for posting this, and the other family group leaders who have been such great partners along the way. And looking forward, if there are other things, personal questions that you didn't want to post, you can also send those to the email address as well. We look forward to continuing to work with you. Okay, have a good weekend, everyone. Bye-bye.